Welcome. Now let's talk about a problem that we frequently face in the ICU. You've treated the patient who's intubated, who's obese, and now you're trying to figure out a way to get them off the ventilator. So we'll start off by talking about lung mechanics and chest wall mechanics in these patients. We'll talk about ideal body weight, and then we'll go on to talk about the utility or lack thereof of the BNP, chest x-ray, and the echo to guide you. We'll talk about diuresis, or something I call blind diuresis. And then we'll also focus on PEEP and pressure support expected. Alright, let's get started. The mechanics are a little different in patients who are morbidly obese, especially when they're on the ventilator laying down. So you have the patient, forgive my bad drawing skills. So you have the large chest wall bearing down, then you have the abdominal wall over here, and that's pushing up against the diaphragm, so that's causing quite a lot of constriction to the ability for the lungs to expand. So you take that into account. What I suggest is, what I do a lot of my patients is I put them in a reverse Trendelenburg position, so you kind of get the belly or the abdomen forces moving away from the chest wall, and then from the chest wall itself, the angle of the pressure will be a little less and off to them instead of going downwards like it was earlier. So that may help in some patients. So consider that when you're trying to prepare someone for extubation. The next is the ideal body weight. Now the ideal body weight is a great guide. It gives us an idea of what target tidal volume we need to achieve, because if you look at a patient, you may be biased in the fact that the patient's large, hence they need large tidal volumes. But in actual fact, if you wait for them to achieve those tidal volumes, you'll be holding your breath for quite a while. So an ideal body weight for females, like I mentioned before, in general vent setup is 45.5 plus 2.3 times the number of inches above 60. So number of inches above 5 feet basically. So if they're 5'4", that's 4 inches times 2.3 added to that. And in male patients, it is 50 plus the same calculation. So this gives you an idea about what sort of pressure support you need. Because in ideal body weight, let's say your target tidal volumes, you want to go within 6 to 8 cc's per kilogram, and the ideal body weight here is 70 kilos. So 70 times 6 would give you 420 cc's. So you know that you need to increase or keep your pressure support, which drives your tidal volume. You need to keep that at a level that will give you that tidal volume. Now you generally you'll accept anywhere between 5 to 7 cc's as well tidal volume, so you kind of don't be too strict on the expected tidal volumes. The next thing to look at is the utility of the chest x-ray or lack thereof. Like I mentioned earlier, the chest x-ray, the BNP, and the echo. In most of these patients, the chest x-ray, because of all the large chest wall mass, you don't want to be able to really have a good idea whether to look for pulmonary edema, looking for infiltrates, let alone look in the retrocardiac area. Everything's going to kind of look a little hazy, so kind of reducing the utility of getting those daily chest x-rays. BNP as well, the lack of validation in obese patients is a concern. There's been some studies that suggest that checking a BNP before and then during a pressure-supported ventilation trial itself may give you an idea whether these patients have any sort of cardiac dysfunction. However, again, this is not validated in obese patients specifically, so I caution you about using that. And you don't want to leave a patient on pressure-supported ventilation for 3 hours before the BNP value comes back, because they will tire out. And echo as well won't have adequate windows or adequate windows kind of assess whether the patient has diastolic dysfunction. And that's one thing that I've noticed as well. Many obese patients have subclinical or undiagnosed diastolic dysfunction, so they're prone to develop pulmonary edema, especially if their blood pressure is mildly elevated, increasing their afterload, or they even have in these patients, especially they will have diastolic dysfunction. I'm assuming I know how to spell that. But anyways, yeah, you have to monitor the heart rate on these patients, the blood pressure on these patients, especially when you switch these patients over from positive pressure ventilation to spontaneous ventilation, or SBT, or spontaneous breathing trials. Even when you extubate them, the change in mechanics is pretty drastic in some of these patients due to their diastolic dysfunction. It gets more pronounced, and they tend to develop pulmonary edema. So it's important for us to kind of consider the utility or lack thereof of all of this, and that takes us to our next segue, which is blind diuresis. I tend to employ this in these patients, and what I do is I take note of what the patient comes in terms of the bicarb value, on admission, that gives me the best idea of what their baseline is, or even their ABG on admission, to see where their baseline PCO2 is and what their baseline that's PCO2 and their baseline bicarb. So it kind of gives me an idea of what to target. But anyways, you can go ahead and start diuresing these patients. You monitor the creatinine level so you don't over diurese them. And you also want to recheck an ABG because you don't want them to be in alkalosis, contraction alkalosis that will reduce their respiratory drive as well, and then you'll have apneic episodes. The other thing is that when we put patients on the ventilator, especially obese patients, if they were hypoventilating before, you may hyperventilate them, get their pH up pretty high, and cause a respiratory alkalosis that needs to be corrected as well. So in these patients, blind diuresis tends to help, like I said, monitor the bicarb level, monitor the creatinine level, and help that guide you. What you can do is also have all their drips and so on minimize. You can have pharmacy to concentrate all the drips to reduce the amount of or keep their fluid balance somewhat even or negative if possible. The next thing to talk about is the pressure supported ventilation trials, or PSV trials, spontaneous breathing trials. Now there are two components to this. One is a PEEP and one is pressure support ventilation. What you want to do is keep the PEEP between 8 and 10, especially in morbidly obese patients, just because the lung mechanics and the way it works, they tend to have increased risk for atelectasis and reduced FRC. So the oxygen levels drop pretty drastically if you don't keep their PEEP levels slightly higher. Now, most normal patients, PEEP of 5 would be adequate, but you have to take note in some obese patients, you will need a higher level of PEEP. Now, PEEP pushes for oxygenation due to its role of increasing your functional residual capacity and avoiding atelectasis. Pressure support ventilation will be focused on getting the tidal volumes in and out. So you will have, that will, what we'll do is it'll guide your PCO2 level. So you want to start your pressure support ventilation, or pressure support, that's not V, it's just pressure support, between 8 to 10. So let's say you have a PEEP of 8 to 10, okay, in these patients. You'll add on a pressure support of another 8 to 10 to them, and you'll then have the ideal body weight to guide you what the tidal volume should be. So for example, if the tidal volumes should be in the 400 range, you will start with a pressure support of 8 or 10, and if you see the pressure support bringing in tidal volumes way above 400, let's say 450 or 500, you know at that point you can probably reduce your pressure support down to about 4 to 6 above the level of the PEEP. So that will give you an idea that the patient is doing pretty well and they need minimal pressure support. So once you're ready, once the patient's on PEEPs of, like I said, 8 to 10, and pressure support PEEP differential of about 4 to 6 in these patients, and they're pulling in decent tidal volumes as based on the ideal body weight, you check an ABG, they're not in respiratory acidosis, and you then want to prepare them for extubation. What you want to do is have bi-level ready at bedside. I find this important because, like I said, mentioned as well, when they come off positive pressure ventilation, some of them may develop respiratory failure due to pulmonary edema. Some of them as well, just due to their lung wall mechanics, may hypoventilate and tire out after a while. So have bi-level ready at bedside. Whether you end up using it, I tend to be a little cautious and extubate them to bi-level, and I use the same pressure support and PEEP levels that I've used on the vent to kind of match that and kind of step them down, and then you can slowly wean that down if needed. However, at night, be cautious. A lot of these patients, especially if you've seen their bicarb level on admission, if their bicarb level is above 28 on admission, then there probably is an element or suspicion for obesity hypoventilation, and you may want to increase the bi-level at night to maintain the respiratory efforts. Now, so that's about it. We covered the lung mechanics in these patients and putting them in reverse Trendelenburg position. We talked about ideal body weight and their target tidal volume. We talked about how chest x-rays, echoes, and the BNP are not all that useful. And then we went on to talk about blind diuresis in these patients due to the undiagnosed diastolic heart failure, and maintaining their heart rate, keeping their blood pressure somewhat normal, and the risk of converting from positive pressure to spontaneous breathing trials, along with just spontaneous breathing when they're extubated, and the risk of developing pulmonary edema. And then we talked about the level of pressure support and PEEP in these patients. Following that, we talked about getting them to bi-level. Now, If all of this doesn't work and they keep failing it, then you'll have to definitely consider tracheostomy in these patients. So that has to definitely be a consideration. Now, if you get them off the ventilator as well and you're trying to avoid them coming back into the ICU, if, for example, their bicarb levels were elevated, there's some evidence in getting them non-invasive ventilation when they sleep at night, and that will help with their hypoventilation or the obesity hypoventilation to avoid their readmission. Alrighty, I think that covers it. Thank you.